everybody, or good afternoon, depends on when you're watching us. But welcome to a very special edition of Finding Wisdom. Thanks to my great colleagues in Queens Public Television, today is a very unique episode. We're going to discuss something that's special to my heart. The name of the show is going to be Queen's Queen of Diabetes Information. I think somehow I became a queen of diabetes information. We're going to discuss a disease that's affecting quite a few of us. More importantly, people from all over the world, not just our American people and patients and residents, but people from all walks of life. My name is Melina Cantor, and I will try to be your humble host. So without further ado, I came to put together a wonderful group of friends and colleagues who are amazing in what they do, and they are quite experts in their field. So I'd love to introduce to you who they are, so this way you know who to ask for help when you do have this disease. So without further ado, we have Dr. Devika Prasad. She's a family practitioner. We have Mr. Noah Reifman, who's a pharmacist, and a great friend, Ms. Constance Brown-Riggs, who is a certified diabetes educator as well as a registered dietitian. So they will tell you guys who they are and what they do well and how they do it. So that without further ado, Devika, tell us what you do and how you do it.
I'm a family practitioner in the South Ozone Richmond Hill community. My job, obviously, as a physician is to diagnose, treat, and a large part of what I do is to educate patients as well. Diabetes is near and dear to my heart because genetically it runs in my family. It runs also in the West Indian population. The bulk of my patients are West Indians, East Indians, African Americans, and Latin Americans. And we know demographically that is the populations that you see diabetes in such ridiculous numbers, actually. A large part of what we do in my office is obviously on their physical exam. You have to speak to the patient, discover their signs and symptoms. It's like detective work. They come to you with the signs and symptoms. Your job is to find out what they have. We use, obviously, weeding away, and we use diagnostic testing to help us to make a diagnosis. Diabetes is a big problem, and I cannot say that it's due just to lack of education, because due to the internet, due to television, there is a significant amount of information that is available. What we need to try to understand is how we can get our patients to try to take it seriously and to try to help themselves and to help their children to understand the disease process, to take care of it.
Great. Thank you very much for sharing. That's very insightful. No, what do you think?
And thank you, Melina, for having me.
Excellent. Thank you for being here.
My name is Noah Reifman, and I am a clinical pharmacist, consultant pharmacist, and I try to help the patient understand the outcomes could be so great if they're taking their medications and actually, implementing certain therapeutics properly. So many times I see very common glipizide, glucotrol. The patient doesn't know when to take it. They think they could take it any time during the day, but we'll get the most benefit if we take it before breakfast at a certain time during the day. And our insulins, as we know as well, right? The short, quick-acting insulins, you have to eat pretty soon afterwards, otherwise with quick onsets. And if they get caught on with a telephone call or, they've done their insulins, what the outcomes are is that if the therapeutics is good, then the outcomes, some of the side effects that we see from diabetes, we spoke about it, retinopathy, neuropathy, and some of those side effects could definitely be inhibited and be prevented if the therapeutics is proper. And many times they just get prescriptions from prescribers, and there's not enough information. When, where, how, what do I do to compensate? How can I get the most out of my therapeutics so that the outcomes are positive and then we have very beneficial, less kind of side effects? So that's what I love to do. I talk to the patients, and we kind of get a feel for the biopsychosocial, what's going on in their lives, and I try to match up the therapeutics with their lifestyles to get them the best quality of life possible.
That's
so thanks
great.
for having me.
Thanks for your insight. And of course, go ahead, Connie. What do you
Hi.
see? Hi.
Constance Brown-Riggs, just to make sure, I'm registered dietitian, certified diabetes educator, as you know. And I'm in private practice, and one of the things that I do, of course, is try to, as I say, clear up the confusion and ease an individual's fears. There's a tsunami of information. Much of it is misinformation on the internet, as was mentioned previously. And so when individuals come into my office, as I said, what I have to do is kind of dismiss the myths. So I say, get rid of urban legends, calm them down, ease their fears, and give them instruction on how to eat so that they can manage their diabetes in a safe and healthy way. Oftentimes, when someone comes in, they're really restricting their food, and they may be restricting to the point of almost starvation. So in a sense, I give them their life back. I empower them. And I like to think of myself as a facilitator of change, so that I, number one, will empower them. Number two, I will motivate them. And number three, I will inspire them to live healthy with diabetes.
Well, that's
Nice.
great. Thank
That's
you all for
wonderful.
sharing. This is really, really, hopefully not new to some of our viewers. Hopefully it is new. So this way they do look at their pharmacist or their family care practitioner differently, and of course seek out a certified diabetes educator. So does diabetes discriminate? What do you guys think?
Definitely not.
Absolutely
Right.
not.
Do we know that there's statistics that always say, well, certain group of subpopulation, whether it's African American or West Indian or maybe Latin American, are more at risk for developing type 2 diabetes? But in this day and age, what do you see now?
I think it pretty much goes along with the statistics. What I will see coming into my office, it's the majority that have type 2.
Right.
We look at are going to be African American. We'll say of African descent. So that
Right.
can be
Yes.
West Indian. It can be the African American or someone from Africa. Recently migrated here, and they will have diabetes. So it's pretty typical in terms of what I see in reality.
I think we've seen a doubling of diabetes in the last 10
Correct.
years.
Definitely.
They think that by the year 2015, 15 to 17% of the population will have diabetes. So it tells
Frightening.
us that it's not a discriminatory disease because it's affecting such a wide population
Yep.
and such a large number that we have to really, really watch it. No matter what your genetic disposition may
So
be,
this
it
is
could occur to anybody.
WHO's statistics, so it goes exactly to what you said. So
Sure.
170 million in 2000, and by 2030, at least 363 million.
It's
So-
incredible.
Wow.
But one thing that kind of came to mind, we always used to think, well, it's an endocrine disease, right? Because it's an endocrine. We see an endocrinologist, and hopefully in the future episodes we will have an endocrinologist here with us to kind of discuss what they do and how they help the patients. But it's a cardiovascular disease. What are you most, not afraid, but try to tell patients to not get to? What are the complications that you look for, not forward to?
Well, I can tell you from my point of view, when you're saying it's a cardiovascular disease, 100% it's a cardiovascular disease. It puts you at the highest risk for heart blockage that exists out there compared to even hypertension in the past. Not only is it cardiovascular, it's a renal disease, it's an ophthalmological disease, it's a urological disease.
Right.
It affects so many of your body parts at this
It's a
point.
multi-organ disease,
It's a
right?
multi-system disease, absolutely. For men, I tend to push their eyesight, I tend to push their sexual function because it does affect those things more so than anything else. Peripheral neuropathy, it's a neurological disease.
Oh.
So many complications that can arise from diabetes, and so many can be arrested if you really just educate yourself and take care of it, do the right things, eat the right things.
What are the right things to eat? I mean, we hear it so much. I mean, come on. Connie?
It's really, it can be confusing, as I said, because there's so much information
Right.
out there on the internet and in popular, health magazines that
Right.
people
they
are reading.
glorify the disease, I feel
And-
like.
Well, and I think the tendency is most of those people will say in the commercials or in the magazines, they're selling a product.
Right.
And that can be very misleading to
Okay.
the individual.
Agree with you?
So basically, for anyone with diabetes, it really boils down to following the dietary guidelines, to eating whole grains. People tend to think of carbohydrate as being such a bad thing. The fact is the body requires carbohydrate in
Brain
order
feeds
to
on
live.
glucose,
So,
correct?
but it's healthy carbohydrate. It's not cookies, cakes, and candy. It's whole grains. And when we talk about whole grains, it may be in the form of cornbread, thinking in terms of traditional soul food.
Right.
people don't often think of cornbread as being a whole grain,
It is.
but in fact it is a
It's a
whole
better
grain.
whole grain.
So, sure. So it's educating individuals on just one, what is carbohydrate,
Right.
where is it found, and basically it's found in everything that you eat except for pure animal protein and fat. It's that simple, and that's what I tell my patients. You know, they say, well, lettuce has carbohydrate. Yes, it has some.
So a little
Fruit,
fiber.
they're
because
many
amazed
fruits,
that fruit
yes,
has
many fruits.
carbohydrate.
A lot more than we
They're
should.
amazed that milk has carbohydrate.
Of course,
And,
vegetables.
and sure, so
Vegetables have
that's, I
carbohydrate.
sum it up. Everything except for pure animal
ahead.
protein and fat is going to have some carbohydrate.
That's great. And I think what Dr. D said, which is really important, is that since the disease is so widespread, we really have to instill some fear in our patients to see what the end of the tunnel may bring. I mean, if they lose their eyesight, can you imagine losing an
Cannot.
eyesight
Cannot see
or
a
having
franchise.
such,
Absolutely.
you know,
Well, my goal is
pain
maybe in the
or-
future we'll have like an ulcerated foot, and I will be your guinea
No,
pig.
Right.
I
we
am
don't want to have an
gonna-
ulcerated foot.
Why not?
No.
Well,
What it
you could
looks
show
like,
that,
I mean,
sure.
We can bring
What
you
it looks
pictures.
like.
That's
We can
not a
bring
problem.
We
pictures. Bring in
have
a
to-
makeup artist. That would be fine.
We have to be there to
I can
help
bring you
our
live
patients, but we have to be there to instill
Right.
the fact that this could be
Well, let's look at it from this way. We don't want to frighten them, but we
No.
do want to enlighten them.
I
The
like
old
that.
cliche.
I agree with
And
you.
that's
Right.
really it. We
I agree with
want
you.
to enlighten
Well
them,
put.
but not frighten
Well
them.
So-
put,
It's true.
but they
the
have
thing-
to see
Yeah.
that we're talking
Sure.
serious business here.
Sure.
We're not, you know, okay, we'll
The one thing I
take.
think is a
eat,
big
I won't eat.
misconception, and help me to, because this is what I understand. Even though sometimes even the IGT, glucose tolerance test, you know that they have prevalence, but by the time they get diagnosed, one thing patients don't realize, the disease has been dormant for like 10 years prior to even showing the clinicians, you guys, that's actually within the body, right?
Right.
Absolutely.
I
So
think
true.
that's one of the reasons that in more recent years, the push and the thrust has been in terms of pre-diabetes. Because at that point is when they have the insulin resistance. And when you see some of those markers, you'll see the triglycerides elevated. You'll see
Blood pressure
the
elevated.
HDL low
High,
and the
and
LDL is
LDL
high. The
high.
bad
Right.
cholesterol is high,
High.
and the good
Good one is
cholesterol
low.
And
is
the
low.
trigs are too high.
Sure.
Got it.
So you know that's that pre, and I'm always doing this because I have a
Continue.
diagram on my desk that I show to my patients, and I show them the natural history of diabetes.
Progression.
So certainly, there is that period of time where they're in that pre-diabetic state, and that's what we want to capitalize on and catch them at that point and prevent them from kind of crossing over the line. As I tell my patients, I show them and let them know you're here. You're in that pre-diabetic state. Absolutely, there's something you can do to prevent going on to develop type 2 diabetes.
I try to capture them even as children. I can tell you like 15 years ago when we first started in our residency, we were practicing, no one was doing cholesterols on 5, 6, 7, 8-year-olds.
Yes,
Now we
that's right.
routinely do it.
Oh, yeah.
And we're actually capturing a younger population because we're checking their A1Cs. If I see someone 5.8, 5.9, someone think those are great numbers. I say, no, you're starting to get at risk. This is the time to start watching your diet, avoiding concentrated sweets, exercising, watching your weight. We have to capture the children.
And I love hearing that because so often the unfortunate reality is many physicians don't. They don't emphasize. They'll tell the patient, well, your blood sugar's a little high.
Right.
We're just going to watch it. Not emphasizing that now is the time for you to take action.
Absolutely.
That if you take
Well,
action
teenagers,
now,
think
you
about the
can
Pima
prevent
Indians
it.
in I believe it's in New Mexico. I mean, the prevalence of that small subset of population at the age of
Sure.
15.
Absolutely.
I mean, it's mind-boggling. They're not even real adults yet.
Well, we see, and I think you just mentioned it, we
Yeah.
see young children, 5, 6 years old, being diagnosed as type 2. So,
Okay, so we know it all.
And also screening. It's not as, we always, in every pharmacy, or you go in, you get your hypertension, you get your, blood pressure
Yeah.
screened, If we started screening for diabetes at an earlier age, then we can pick up the pre-diabetes and possibly avert a lot of complications.
And there's something else that you mentioned in your intro, and I guess all this is so fresh in my mind because I teach classes on managing diabetes to other healthcare professionals, but with the pharmacy and the medications, and it's so important for those patients that have diabetes at this point in time that are on medication, that they speak to the pharmacist, that they make sure that they understand how they should be taking that medication, when they should be taking it, because oftentimes they have no clue.
Well, utilization is so important. I may be taking a drug, but getting 50% of the effect out of the drug.
That's right.
So what do we do? We add another drug.
Absolutely.
And then, because we're not
That's right.
taking it properly,
That's
we're not
right.
taking it
That's
before
right.
meals, we're not taking it in the right cycle.
That's
So,
right.
and then we get into polypharmacy.
What
and
about drug and food interactions? What do you think about that?
Absolutely.
I
you
think
know?
that's one
That's a
big myth.
key for the
Yeah.
oral hypoglycemics are very dependent on before meals, with meals,
That's right.
and we don't tell our
Sure.
patients enough to
And
get them through.
Patients don't tell their physicians.
You know,
enough either.
Absolutely.
I
Yes.
find that.
Yes,
Oh,
yes.
yes.
So,
And so they're not following their meal plan. This is what I see
Yeah.
all the
Getting
time.
information is like
Right.
pulling teeth.
Right,
Right.
especially
Very
for,
tough.
for the physician. Thank heavens I have more time with them and I can get some information from them.
Right.
And this is one of the things that I've discovered. They'll go to the doctor, they haven't been following their meal plan, and of course you assume they're doing what you tell them, or they're taking the medication
course.
as you prescribe, but they're not. They don't tell you that. And
I
so
can
you
tell.
look at their A1C.
I can tell by looking
Okay.
at the numbers.
But oftentimes
numbers
they'll-
don't lie.
But this is
My
what I'm
favorite.
saying. They'll look at their A1C and everything is elevated,
Right.
and then you may prescribe more medication. And then on their way home, as they're driving home, they decide, I really need to eat better. I really should do better than what
Right.
I'm currently doing.
I'm not gonna
so they
take
go
this.
or I
home.
should just be
they go-
honest with my physician
Exactly.
and say, you know what? I cheated. I'm not really
But they won't do that.
adhering to
They
the.
won't
Well,
They
my
won't
favorite
do
is
that. And then,
they know
Won't
they're
do
going to
it.
take a fasting and usually say, come in fasting. So say, okay, I'm not going to eat, drink, do anything
Oh, many
the
people.
night
That's
before.
right.
Absolutely.
And
That's
I'll
right.
be okay.
Walk on the treadmill the night before for an
yeah,
hour.
Yeah, I like that one.
I look at
That's
the
why-
A1Cs.
Yeah,
I look at the
A1Cs don't lie,
A1Cs.
you
Yeah,
know.
but
I can
what
tell
is
you that.
A1C? Because I think they
Oh,
really
that's a good
don't
question.
understand.
Yeah.
I love this analogy. So I had a good colleague who said, well, when you come to see a physician and they monitor your blood pressure, you get two numbers, systolic and diastolic. When they come for diabetes testing, you get an A1C number. One thing they don't realize that it's both fasting and postprandial or
right.
post-meal. What do they say, PC and AC? But the Latin terminology, I don't think we use that here anymore. But those are the two numbers that have to go together. So if your fasting is too low and your post-meal is too high, wouldn't you get a normal A1C?
Not necessarily. I have
No,
many
because
patients who have beautiful fasting sugars, and they do exactly what you said. They're coming in there starving for like 12 hours.
That's right.
And then you look at their A1C, and it's 6.5, 7, and I said, you know something's wrong. The problem is when they're eating, their body is just not generating enough natural insulin,
Right.
and what's happening is the sugars are going up.
Sure.
and an A1C is a 3-month
It
Yes.
tells,
kind of
yeah,
a
I always
value.
tell them,
It's not a
yes.
24,
Yes.
12-hour
no,
marker.
It tells me
It
how your
tells you
sugars
the
are
picture of
for the
what's
past
gone
3
on
months.
for
Yes.
3
So-
months.
24/7 for the previous 3
3
months.
That's
and what I
right,
think they
right.
really should understand, maybe in the future shows, we'll do like a little animation. I just learned that A1C is really the amount of glucose molecules attached to the red blood cell,
Yes,
That's right.
the
That's
amount
right.
of surface area of the blood cell that are occupied for the last 3 months.
that's right.
So if your number is 6% of the sugars have been living in your red blood cell.
Right.
If it's 7 and more, God forbid, then it's even more.
That's
So
right.
what does that mean? So if the sugar is, we just discussed this, and it's a barometer, right? How sticky is your blood? That's how I think. Because somebody had said to me that if your sugar is A1C of 13, and I just heard
Oh my God.
A1C
You
of
don't want an
16.
A1C of 13.
Right.
Yeah. Yes, yes.
You've
then
seen
you're
that?
talking
Have
of
you seen that?
Viscosity. you're
Viscosity
starting
is
to-
like
Yes.
molasses,
Yeah,
Exactly.
right?
Exactly.
I think you might have even
You're
heard it from me
absolutely
from
right.
one of your lectures.
That's what I always tell
Yeah.
them.
Yeah.
It's it's just like molasses.
So what happens to your microvascular, your little capillaries that is in front of your eye at the A1C of, let's say, 10?
You're getting platelet buildups in your blood vessels, not just your eyes. You're getting it pretty much everywhere. You've
So
got
the
blood
renal,
vessels everywhere in your entire body.
Small vessels.
It's a setup for coronary artery disease.
Sure.
It's a setup for blockage
Definitely.
in everything. Your eyes, retinal hemorrhaging. So many problems can happen. Your kidneys, everything.
Okay, so we do know that it's dangerous.
It's
So-
a scary
Absolutely.
disease.
Absolutely.
Right. So, in terms of prevention, and we touch a lot on it, obviously taking good care of diet and exercise, and we all know this, we all try to do it. Type 2 prevention, you clarified me and you
That's
specified
right.
me. Sure. So if you were to just give, maybe we'll go in a row and just say, well, today, just because it's our first show and we're just kind of starting, let's say I get diagnosed today I came in, you are my doctor, that's for sure, and you say, William, that's it. It's either do something or give me a couple, maybe two pearls. Moving forward, what can I do today?
The first thing I'll tell you is weight loss and diet. And I actually do, I'm one of the, probably the first, one few physicians, I'll sit with the patient, I'll go through the diet. And I tell them,
Excellent.
I'll say, go through it. After a month of looking at it, measuring your food out, you'll understand what the portions look like. You won't have to measure anymore, but just get a basic understanding. And I'll put you on a set calorie diet based on your body weight and your height.
Well, we've done better, right? We've been good.
We've all done excellent, thank God.
We've been trying. Yes, Rika has seen.
Yes.
Post-pregnancy has not been good, but it's better.
We've been running in the park together.
Yes, that's for sure. Okay, that's great. Noah, you're a pharmacist. You see, I can't. I have bad knees. I'm a 65-year-old woman who's had 5 children. I've carried the whole family. I can't exercise. What kind of exercise can I do?
Well, it doesn't have to be high impact kind of, you know. It could be other type of exercises that don't involve running on a treadmill, maybe softer.
Pilates is excellent. Yoga is excellent for people in the elderly population.
Chair
excellent
exercise.
exercises.
They have plenty of
you
chair
can
videos so you can get an excellent workout sitting in a chair.
Yeah, without running, you know, in the park or
They will not damage your knees.
Right, but diet and exercise are the key components.
Absolutely.
You know,
and what I would tell them is smaller portion. So even if they're unable to follow a set meal pattern, most important is to eat smaller portions. They're currently eating out of a platter, tell them make it a smaller platter.
Maybe a
eventually
instead of a big
not
plate.
if they're eating out of a platter.
Got it.
Because that's not going to work. If they're eating out of a platter, we have to make it just reasonable. But one day we hope it'll be a saucer that they're eating out of. But that's the most important. You know, it's smaller portions, it's losing weight, modest amount of weight, and that's key to let people know. They don't necessarily have to get into, as I say, bikini weight, but they do have to lose something. So 10 or 15 pounds can make a significant difference.
Well, I think the whole purpose of the show, why I wanted to bring everybody together, is because we have the luxury of being in New York. We have pretty much every ethnic group in the world, in Queens and Brooklyn and the 5 boroughs, and kind of marrying the disease, the culture, and the nutrition. Because the way I think my comfort food is not your comfort food.
That's right.
And your comfort food is not maybe the Vic's comfort food, but we all have that. So I think it would be very important for us to understand each other and not to mold. I know we have a beautiful pyramid that everybody's supposed to follow. We are in America, but unfortunately, that's not, we're all from different worlds. So I think moving forward, I think it would be great to kind of understand the disease from a different cultural perspective and then get your advice and your expertise on how to treat it, being who we are, from where we come from, and understanding the disease a little bit more.
That's excellent.
Right?
That's right.
Can we do it?
Absolutely. Absolutely, we can do it.
Sure.
Absolutely.
You
So
bet.
thank you guys. This was fun. Happy Valentine's Day.
Thank you.
And,
you too. And
lots of happy, treated, understanding patients.
Absolutely.
let the outcomes be real
Living
positive.
well with
out of-
diabetes.
Yes, and we'll
That's
talk about the
right.
numbers,
Yeah.
and we'll talk about the goals. We'll talk about what the fasting and the postprandial and neuropathy, nephropathy, all these amazing terms that we discussed today, what they really mean.
Okay.
And I think what's really unique is I think I just read the statistics from American Diabetes Association, and maybe I'll leave that with that thought. And maybe it's a little gruesome, but I know the disease of the 80s was obviously AIDS, and we took a lot of patients and we really try to understand the disease. But I think the disease of this decade could be diabetes, and if we could make it a little bit more controllable. So the StopDiabetes.com states that diabetes kills more Americans every year than breast cancer and AIDS combined. So I think it's
Startling statistics.
startling
Yeah.
statistics. So we as citizens, those who are in the position of empowering others, I think ADA is looking for those brave ones to be the diabetes spokespeople. So I encourage all of us, not just today because we do have this wonderful opportunity, but just spread the word of how to not progress with this disease.
That's what I do every day.
That's why
Every
you're
day in practice.
excellent. And we're hoping that it would be great for others. So thank you for your knowledge and your hard work and your expertise and what you do on a daily basis. Thank you for letting us learn.
Thank you, Melina.
The other thing is, I know that, let's say maybe on the future episodes, something that you guys would like to see, maybe we could, obviously nutrition and cooking, and it's all of us, we love that. At least we have those. I have a few weaknesses, and then those are the ones. But something that you would like to see in the future episodes, something that maybe we could work on together.
I think one of the things that I really would love patients to get a better grasp of is maybe if we can get some models of just, basic things like an artery, just so they can see the progression of early stages and end stages of heart disease. Same thing with models of the eyes, if you can get an ophthalmologist.
Okay, I have a wonderful.
Because honestly, I'd rather lose a hand than lose my eyesight. I can't speak for other people, but I know for myself.
Eyesight is
You know?
very scary.
Yes.
Definitely.
I have a moving forward, just so you know who I already worked on, we do have an endocrinologist on board, a podiatrist on board, and an ophthalmologist on board.
Excellent.
So those are the three, and the whole idea for the show is I'm bringing on board the team approach. Who is every diabetic need to know? So if I were to put together a board of trustees, if I were running a company, right, those are the people who would be on my board of trustees. So for diabetics, I think a family practitioner, a pharmacist, a certified diabetes educator, podiatrist, a nutritionist could be one or the sometimes.
I wear both hats.
You wear both hats.
Registered dietitian, certified diabetes educator.
So that's huge. And a lot of times patients don't know that this subset of clinicians does exist. So I think that would be great to highlight that. And psychologist. What do you think about a psychiatrist?
Absolutely.
Right?
Absolutely.
Absolutely.
So many
for
people.
families, maybe for
Well,
families.
depression,
Not only
you know what? When you get diabetes,
Yes.
you get into the whole mode
Oh,
of
absolutely.
depression
Absolutely.
and fatality. There's
And guess
so
what
much.
else? Deniabetes also.
I like that term.
Deniabetes.
I hope you coined that.
Gotcha.
I like that.
It's in my book, Deniabetes,
Right,
because
right.
so many people at diagnosis are in denial.
Right.
And that's part of the problem.
Well, we're going to
so.
try to clarify what any questions they have, and maybe we'll get some good questions for all of you. Once again, thank you for your expertise.
I'd
Thank
like
you
to
for
see some dancing molecules. if we
dance
can.
molecules. Oh,
Nice.
No, you know
Sounds
what I
good,
mean.
right?
No, little pharmacology that's
Sure.
Absolutely,
animated and
let's-
show receptors and
do it.
how drugs.
No, I think
you
I
know,
would
We're going
love to
shopping.
show.
We're going to
Yeah,
go
we
shopping.
could
We've
do
got
that.
to talk
Definitely
about
gonna
the
go shopping.
food
We'll talk
aspect.
about
Okay.
But I think also showing them what A1C looks like.
Yes.
A blood cell without
Yes.
the glucose molecule and a blood cell with.
Yes.
And maybe children can help us. So thank you all for watching.